Okay, good afternoon, everybody. We will get started now. Today we have Dr. Aggie Gao and Dr. Anin, who are PGY3s in the Western Internal Medicine program, presenting a case that they encountered. And I guess the title gives us away that there's pericardial effusion. So we'll do a little bit of discussion and teaching around the case. So without further ado, I'm going to give over the microphone to Aggie and Anin.
Hi, everyone. Thanks for joining us for this presentation. This is the end of our POCUS block. So we will have a case surrounding pericardial effusion and a primer on kind of the importance of POCUS investigations for these pericardial effusions. So we're going to start with the case that we saw. This is a 73-year-old female that was initially admitted for dyspnea and as well as fever NYD concerning for congestive heart failure exacerbation. Her past medical history is most concerning for HFpEF, which actually has already been recovered due to goal-directed therapy, as well as metastatic breast cancer to the bone, which most recently suggested that there is even more metastasis to bony mets, and she was recently admitted to hospital for pain. She also has chronic kidney disease as well as atrial fibrillation, currently on apixaban, and I have listed her medications on the right side of the screen. The history presenting illness was that she recently was actually hospitalized because of weakness and pain for her metastatic breast cancer to the bone. And since she's been going back home, she's been having increasing dyspnea as well as orthopnea, as well as these intermittent fevers without any other viral symptoms. And so, of course, she came in and she had her COVID test done. Even though she had positive COVID contact, she was actually COVID negative. This is her initial chest X-ray on the day per admission. So vitally, her blood pressure health was fine. She was, 93% on room air, not really that tachypnic. Her heart rate was about 73, and she was febrile with a temperature of over 38. And if you take a look at her chest X-ray, you can see that on the left-hand side, there is increased interstitial markings with known cardiomegaly. And from the lateral view, you can see that there is bilateral pleural effusions. In addition, her investigation was actually quite concerning for possible tumor lysis syndrome, given the fact that she had elevated potassium, this really high CKD, as well as elevated phosphate and urate. So she was treated as a possible TLS also in the beginning of her admission. So the first set of management that has done was for her dyspnea, the admission team felt that she was volume overloaded given her HFpEF, and so she was fluid restricted and given IV diuresis. On CTPE, there was no sign of pulmonary embolism, and this was done especially given the fact that she has malignancy. For her fever, they actually didn't find a true cause and felt that this is likely a fever or malignancy, so she was not treated with any antibiotics. And for this possible tumor lysis syndrome, they did give her, an episode, a dose of Respiricase, which everything normalized. So she was doing fine for about 3 to 4 days, but unfortunately, she was still feeling quite dyspneic. So the team decided to repeat the chest X-ray. And this is a repeat of her chest X-ray approximately 5 days later. So on the chest X-ray report, there was concerns due to this new globular morphology cardiac silhouette. And so in the chest X-ray report, the radiologist recommended to rule out a possible large pericardial effusion. And you can see even though this is an AP view, they felt that this morphology, even taking consideration the fact that this is AP in comparison to previous PA view, that this is very enlarged. And of course, the daytime team felt that given she is so dyspneic, is she in cardiac tamponade was the question. So the POCUS request was, is there a newly developed pericardial effusion and is there tamponade physiology?
Okay, so I'm going to be talking about a little bit of a primer on pericardial effusion, the physiology, and then going into some of the ultrasound views. So the most important thing when looking at pericardial effusions on ultrasound, first is knowing your pericardial anatomy. So we have our visceral layer, your parietal layer. We often see it as a hyperechoic white line on, this is on your peristernal views, and you can see the two lines that are here. One important note, you want to make sure you have enough depth that you're able to see your descending aorta. And this helps distinguish your pericardial fluid from pleural fluid, because your pericardial fluid will be anterior to the descending aorta, and your pleural fluid will be behind it. The pericardium functions as a way to be mechanical protection and to reduce friction throughout the cardiac cycle. Normally, there's around 50 cc's of fluid. However, the pericardial fluid can cause a lot of hemodynamic compromise and reduce cardiac output even at 150 cc's or 200 cc's if it's accumulated rapidly, or for more chronic pericardial effusions, the sac is able to hold over 1.5 liters of fluid, depending on your rate of accumulation. So just looking at some of the physiology behind pericardial effusions and how it causes hemodynamic complications. When you have fluid accumulating in your cavity, you have an increase in your pericardial pressures. And the lowest pressure chamber in your heart is your right atrium. So that is the one that's first affected. So when you have this fluid pushing in, it causes, we'll talk about this a little bit on your ultrasound windows, but you're pushing in first to your right atrium. And that can cause increase in your right atrial pressures, and downstream it could cause venous congestion with decreased venous return and increase in systemic venous pressures. On the left side of the heart, once the pressure is building up further and further, you can also have increased pressures in your left atrium, and which reduces your LV and diastolic volume. Normally your heart in the earlier stages, and again, depending on your rate of accumulation, first counteracts this by increasing your heart rate and increasing contractility to maintain your stroke volume. However, at a certain point, when the fluid keeps building up and the pressures get higher, you have your heart can no longer compensate, and that's when you have your reduction in stroke volume, hypotension, and you have issues downstream with your systemic perfusion. So some of the causes of pericardial effusions, often we don't know what causes pericardial effusions, but in terms of workup, one of some of the things to think of would be infectious causes, bacterial infections, viral pericarditis, inflammatory conditions like rheumatoid arthritis or lupus, malignancies such as for folks like our patient here, autoimmune conditions, myocardial infarctions, or when we look at Dressler syndrome, trauma, post-cardiac surgery, and vascular conditions, including thoracic aorta dissections. It's important to have to have good suspicion for this, because pericardial effusions can often occur over years. Folks to think about to keep an eye on, or if they have a potential pericardial effusion, is if anyone's had any pericarditis, post-operative patients, folks who have, especially on chest x-rays often, who have enlarged pericardiac silhouettes without pulmonary edema, or really people who decompensate with diseases that could potentially affect your pericardium. And as you can see, the differential for that is quite broad. So some of the signs and symptoms, so most of these are based on the JAMA articles about what's most common. Often folks will present with dyspnea and chest pain. Other symptoms of this are palpitations and tachypnea. As you can see, those are very non-specific symptoms, and that's why it's important to keep a high index of suspicion. When you look at the examination, in vitals, when we talk about the decreased venous return and the compensatory tachycardia, that's one of the first signs we see for folks with pericardial effusions that are starting to decompensate. The hypotension often happens later on. Not often, that is what happens later on in the disease process. Now, looking at our neck veins, something I'm sure we all very closely look at in terms of your JVP, some of the signs that are that correlate well with your pericardial fluid is jugular venous distension. You have absence of your Y descent, and if you remember from the JVP waveforms, that's often, or that is correlating with your passive ventricular filling. And when we looked at the pathophysiology slide, there is interdependence there is a equalization of the pressures as the pericardial fluid accumulates between your right atrium and your right ventricle. Pulsus paradoxus has the highest likelihood ratio in terms of for physical exam. So that is when you're measuring when you're listening for your Korsakoff sounds, and it's normally less than 10 millimeters of mercury drop between inspiration and expiration is considered normal. Greater than 10 We call it pulsus paradoxus. It's, I guess, more, rather than being paradoxical, it's more exaggerated. Auscultation, once there is significant amount of fluid building up, it can be difficult to hear your heart sounds, and you can have that pericardial friction rub. One thing that we're often taught in our exams is your Beck's triad of distended neck veins, hypotension, and muffled heart sounds. That's, from most of the studies I've found, that is present in maybe 10% of patients, and it's often a late sign of pericardial fluid accumulation. So just some other findings, looking at this ECG, you can see that there are reduced voltage, that there is, this is electrical alternance. You can see the axis shifting, particularly in your precordial leads. And the other common finding in ECG is, of course, your sinus tachycardia. And just looking at the X-ray, that what I want to point out here, this looks very similar to a patient's X-ray. You have an enlarged pericardiac silhouette diameter. I'm being very careful not to say it as just cardiomegaly, because in that case, we can miss a lot of pericardial diseases, and often with absent lung markings. So going back to this slide, POCUS is our gold standard for diagnosing pericardial effusions, and it can also help us figure out the degree of hemodynamic compromise. Cardiac tamponade is on a spectrum of disease, and it's often, it's a spectrum. It's not clearly a black and white between yes or no. However, it is a clinical diagnosis, and POCUS will help us find folks who are at risk of tamponade or whose pressures have resulted in tamponade physiology. So the first step is making sure we're looking at pericardial fluid. So just looking at the two images here on the left, you see that the fluid collection is anterior to your descending aorta, which indicates it's pericardial fluid, and on the right, it's posterior to it. Another common point to keep an eye on is epicardial fat. We often see that especially around your RV, and it can also appear as hyperechoic and can be mistaken for pericardial fluid. So characteristics of, I'm just going to go over a few stages of pericardial effusions and what to keep an eye on. The accumulations are often first seen right anterior to your right atrium. So on this apical view, we can see where it's labeled PE, some pericardial fluid accumulating there. There's other ways to characterize based on size. Fluid in the pericardial sac for medical conditions usually circumferential. However, in certain instances, particularly for post-surgical patients, the fluid can be localized. So just looking at a video of fluid in the different views. So if you can see up top, you have your subcostal, top right, you have apical, bottom left, you have your peristernal long, and on your bottom right, you have your peristernal short axis. So it's important to be able to identify the fluid in different views, and at least to try to get imaging from two views to confirm presence of the fluid.
Sorry, Aggie, and then maybe I'll just ask you to turn off your video. It might give you a little bit more bandwidth for the video frame rate.
Oh, sure. Okay. All right. So one of the other characteristics of effusions is measuring size. So this is one way of measuring the size of pericardial fluid. The way we measure it is you look at the in diastole, and you can use your valves to look at the cardiac cycle and ensure you're in diastole. Take a look at the right ventricle and the distance between the epicardium and the visceral layer. Okay, and the epicardium and your visceral layer, and to measure the distance from there. If it's between half a centimeter to 1 centimeter, it's small. 1 to 2 centimeter is moderate, and greater than 2 centimeters is considered large. So this slide is from the American Cardiology Society guidelines, and this shows essentially how much fluid. On the x-axis you have volume, and on the y-axis you have pressures, and it just shows the difference between rapidly accumulating effusions and slow effusions. As you can see on the right, on the blue graph, slow effusions can accumulate with more volume over time. Pericardial effusions, and especially tamponade physiology, is really a pressure problem rather than focusing just on volume. So again, the rate of accumulation is often more clinically relevant than your size of the effusion. So now going through some of the other stages of pericardial effusions and evolution. As you can see on this image, where it's pointing with the, so it's a short loop with the red pointer, the right atria is collapsing. One of the ways that I've seen described often is, imagine if someone's jumping on the right atria like a trampoline. You can see the collapse, especially it's right atrial collapse during systole, and that is ventricular systole. And remember, the right atria is the smallest chamber of your heart, or the lowest pressure chamber of your heart. It's a quite sensitive finding for pericardial effusions and especially tamponade, but is not as sensitive. On the next view, you can see diastolic RV collapse right along the top of the video. If you see here, the free wall of the right ventricle is pushing towards the septum. And that is a very specific, once you have both RA and RV involvement, it's much more specific for cardiac tamponade. What we're seeing on this image is a very plethoric IVC. As you can see, during inspiration and expiration, there is no collapse, or there's not at least a greater than 50% collapse. This is one way to measure IVC size and collapsibility, and is a surrogate marker for your right atrial pressures. And as you can see in tamponade physiology, because your right atria collapses, you have increased venous congestion. So in this case, if the IVC diameter is greater than 2.1 centimeters and it's not collapsing less than 15%, that estimates roughly a right atrial pressure of greater than 10 to 50 millimeters of mercury. And one of the further stages of these effusions is when you're looking at inspiratory and expiratory variability, and particularly your ventricular size. If you look at the image on the right, when you inspire, you have enlargement of your thoracic cavity, and this increases your negative intrathoracic pressure. When that happens, you have increased venous return of your heart. Normally, this does not affect your LV. However, when you're in the pericardiac sac and you have interventricular dependence, the RV bows, the septum bows towards the LV and decreases LV filling, and therefore your your cardiac output. This in turn can reduce your systolic pressures. And when you expire, the opposite happens. And this is why we see the pulsus exaggeratus or pulsus paradoxus for tamponade. So this is, I just want to show two videos here about that show more severe tamponade physiology. As you can see here, there's right atrial and right ventricular collapse, and you can see some bowing of the septum. And on the video on the right, you can see the heart, again, the septal motion, as well as the ventricular, the septal bowing, as well as the ventricles changing with your respiratory cycle. And finally, I just want to show a quick clip of when you have significant amount of fluid. If you look at the picture on the bottom right, this is when you would get your ECG findings of electrical alternans, because you can see the axis shifting as the heart is swinging about in the pericardial cavity.
Okay, so just going back to the case, so this is the patient that we were able to scan for a possible pericardial effusion. Let me loop this. So this is the peristernal long axis, and just to orient everyone again about the peristernal long axis, so what you see right here is the left atrium. Here you have the left ventricle. This is your aortic valve going into the LVOT, and this is your right ventricle or RVOT. And what you really see here evidently when you put a probe on her chest was that she does have this hypoechoic pericardial effusion, which is just anterior to the descending aorta, which we know that this is pericardial effusion rather than pleural effusion. And you can see that this hypoechoic effusion is not only just present during systole, but actually is present during diastole and systole as well. And so like we mentioned before, that it was really important for us to actually measure the effusion size. So if you were able to measure the diameter of this effusion at end diastole, approximately it was 9 millimeters. And based on our sizing definition, less than 1 centimeter will be defined as a small pericardial effusion. Something else to note on this parasternal long axis is that it seems that her cardiac left ventricular function might be mildly reduced, as the septum excursion is not as intense as what we would expect with normal left ventricular ejection fraction, as well as it looks like perhaps she may have a degree of aortic stenosis given the thickening of her aortic valves over here. The other thing to consider is when you're looking at the size of our left atrium, normally we should be dividing into thirds, into, a third of the size should be the right ventricle, a third of the size should be the LVOT, and a third of the size of the left atrium, but our left atrium looks quite enlarged.
Hey, Aggie, sorry to interrupt. I think maybe there's some minor technical difficulties here. Would you be able to try just looping that again? Just the frame rate was quite bad on my end here. It was better before when we were trying it, but it seems to be a little bit worse now.
Does it look better now?
Not on my end, but I mean, I can poll the audience as well if there are any further questions about the images, if there are any problems there.
Okay, let me see if.
I guess, I mean, I could also just open up to the audience if there are any questions or specific things about the image that can help clarify.
I agree. It looks awful.
Oh, you guys can see the video?
You can see the video is just that it's running at probably like 5 frames per second, 3 frames per second.
I'd say three.
Okay, thanks, Marco.
3 to 5. That was a very good. Yeah, it's like a Parkinsonian frame rate.
Oh, sorry, I don't know why this is
like we can see the structures fairly well. It's a well windowed image. But maybe we can just pause. I guess for these images, we can just pause a little bit and see if the audience has any questions about anything that you were describing.
Would you be able to pause it in diastole?
Fine.
I feel like we should give up on the frame rate.
This is hold on. Oh, here, probably this is better diastole. It's gonna be hard. Can you see that there? This is definitely not full systole.
I guess if you pause it when the mitral valve opens up, that would be pretty close to approximation.
There. That's opening up.
So I guess I got to Marco, you're trying to look for any chamber collapse during diastole. Is that correct?
I'm just trying to learn here, Jeff.
Thank you.
I was.
Let's assume. I'm not sure this is exactly diastole, but let's assume it is for now, Aggie.
Mm-hmm. So basically, because you're able to see the pericardial effusion both in systole and diastole already, this is defined as at least a small pericardial effusion. And when you measure at end diastole, the diameter of it is 9 millimeters. So below 10 millimeter or 1 centimeter, that's a small pericardial effusion. I think when you're looking at right atrial collapse during diastole or right ventricular collapse during systole, it's probably better viewed in the apical view. But we can, if there's anything obvious, we can probably also see it here, but there's nothing here that we see for now. Would you guys be okay if I go on to the next slide?
Yeah, I think so, Aggie. Thank you.
Okay. So here is a parasternal short axis. Let me loop this to, or even just stop it for a second. So to orient everyone again, this right here is the right ventricle, and surrounding this is the left ventricle, and this is the right ventricle. What you see here are the pap muscles. So already you can see that kind of underneath here, posteriorly, there is a pericardial effusion, and it's hypoechoic. So if I just, right here, are you able to see? I don't know if the rate of this video is okay. And here are the pat muscles.
I think we're getting into some similar problems here. One thing I don't know is this just you could try, you see the gear icon there, you could try just turning down the resolution of that playback, see if it makes any difference. It might not. It's already pretty
Right
low.
now it's auto, it's
Okay.
just 360. Yeah.
No, yeah, it's pretty rough right now. Just try to let it loop a little bit, I guess, and try, maybe describe what you're seeing.
Yeah, so what you really see is that the right ventricle, as it's contracting, you can see the circumferential pericardial effusion.
Can you
So
can you
kind
point
of-
out the circumferential effusion for us?
Yep, here, right here.
Yeah, so certainly I agree. There's I think there's a posterior effusion that you point out very nicely. I'm not so sure if I'm seeing it anteriorly. I think that might be it, although it might be nice to have the video playback.
I know. Hold on. Let me see if I can find a better, like here.
And I mean, looking at it, it's a bit gray and echogenicity. So you could argue that this could be either pericardial or epicardial fat. But you need the full video to be able to see it properly, obviously.
Mm-hmm. And maybe in the apical view, it will be better visualized. So we can look at the apical 4-chamber view. I'll just pause this for 1 second for now. So just to orient everyone again, so this is the left atrium, the right atrium, the left ventricle, and the right ventricle. So even before I start moving the image, you can already see next to the right atrium, there's a trace of pericardial effusion right here. And I'll just see if I can loop this. I know we're running into a lot of technical difficulties. Here you can see the effusion right next to the right atrium along here. And there's a traces of it here too, right next to the right ventricle. And what you even notice from this view is that there is pretty significant biatrial enlargement as well.
I think the frame rate is playing fairly well on this video right now, at least
okay.
for
That's great.
For the majority of it, I think. So yeah, good. So
here,
good, yeah, I guess, yeah, that's good. Can you
and
comment
just
on?
to show, yep.
Oh, sorry, go ahead. Go ahead.
Oh, no, sorry, what was your question? I was going to move on to another apical 4-chamber just to show better view of the right ventricle and the effusion next to it, because I know in this view you can't really see it.
Yeah, that's good. Can you, before you go there, can you just comment on the right atrium and comment on whether you think there's any collapse at all?
Yes, sure. So just even on this picture, you can see that what you're looking for is right atrial collapse during systole, and you really see that the right atrium looks quite full, and there's no evidence of that collapse that we tend to see on the videos Anin showed earlier. And I know this is not the best view to look at the right ventricle, so we'll take a look at it in the subcostal view to see if there's any right ventricular collapse during diastole. But at least from this view, we don't see right atrial collapse. And because right atrial collapse during systole is the earliest sign, I would not expect right ventricle to be collapsing during diastole.
I think that's you can just pause that for a second. That's a very good observation, Aggie. Just pause it anywhere. And so, yeah, so again, you need a really good frame rate to really tell whether there's any atrial collapse. But what we typically would see if there is truly atrial collapse is really this invagination of the atrium. So I kind of annotated on the screen there. And I think looking at this here, there isn't any evidence of that. But yeah, that's how we would describe this invagination of the RA free wall as a collapse of the RA. So I don't think I noticed any of that there. That's great.
And then just going on the next, so this is a better picture, just looking at the pericardial effusion right next to the left ventricle. I'll loop this too. So you can see that on this side, you can see it way better when the heart is in systole. So on this side, the pericardial effusion is a tiny bit, at least from this view, looks a little bit smaller and less evident than the right atrial pericardial effusion here. But even just based on this view, we know that this is a circumferential pericardial effusion. And there's no obvious stranding and septation that we're able to observe. So next we look at the subcostal view. And just before I even play the video, to orient everyone again, I'm gonna pause this. So on the bottom here is your left atrium, your mitral valve going to your left ventricle. Here is your right atrium going into your right ventricle. So this is probably a better view for this patient to see if there's any right ventricular collapse during diastole. And there is no obvious right ventricular collapse. And this is what we expect because we don't see any right atrial collapse during systole. And you can see here that there is pretty obvious pericardial effusion kind of near the right ventricle too. And because of the gravity dependence part, we are able to see the pericardial effusion next to the right atrium a lot clearer here. Right here. Before I move on, is there any questions about these images or videos? I'm not sure about the quality. Okay, I'm gonna move on. So lastly, we talked about the IVC, and what we're really looking for is, can we rule out a cardiac tamponade if the IVC is not plethoric and collapsible? If it is plethoric and non-collapsible, it doesn't really rule in cardiac tamponade. So we're looking at this patient's IVC. When we measured it, it was approximately 2.2 centimeters, approximately 1 centimeter away from the hepatic vein, and you don't see it collapsing more than 50% when the patient is inspiring. So that means that her right atrial pressure is approximately 15 millimeters of mercury. Even though this is a plethoric non-collapsible IVC, it does not rule in cardiac tamponade. But if the IVC was completely collapsible, it can help rule out cardiac tamponade. So overall impression of this POCUS was that this patient has a small 9 millimeter circumferential pericardial effusion with no evidence of tamponade physiology on POCUS examination, i.e. there is no right atrial collapse during systole or right ventricular collapse during diastole. We do see that there's biatrial enlargement of the heart with mildly reduced left ventricular function, which is different from her last echo back in the beginning of September, which showed normal ejection fraction, and the fact that there is evidence of elevated right atrial pressure based on her plethoric and non-collapsible IVC. So we talked to the team and they said, well, that's really interesting. Why is her heart so much bigger than before? And we did a relook in her chest x-rays. So on the left side, you have the lateral view of the first chest x-ray she has done on her date of admission. And on the right side, this is the chest x-ray that she was done when they were worried about pericardial effusion. So you can see that the first chest x-ray was done PA and the second chest x-ray was done AP. However, in the second chest x-ray, the patient was actually quite slouched. And sometimes being the slouch position, in addition to her AP form, may make the heart look a lot bigger. So one of the recommendations I did make to the team was to just repeat a chest x-ray to ensure that this is all due to kind of positioning as well as chest x-ray technique. Unfortunately, the patient ended up leaving the hospital because the family felt that she wanted to participate in more palliative care at home. So I understand that this is not exactly the most satisfying resolution of this case, but what we did communicate with the team was that we did not feel that her small pericardial effusion was the etiology of her dyspnea, and that likely the small pericardial effusion probably has been present for quite some time. And thinking about the differential diagnosis of her pericardial effusion, it could be anything between being malignant due to her metastatic breast cancer, could it be infectious as she was having maybe a COVID contact or some viral infectious symptoms prior, or the fact that she had possible tumor lysis syndrome with this AKI on CKD, and whether this could be uremia. So some take-home points about our presentation today. So we know that cardiac tamponade is a clinical diagnosis, which we should think about when there's a patient with elevated JVP, tachypnea, dyspnea, as well as a positive pulsus paradoxus. And the fact that the rate of accumulation rather than the size of the pericardial effusion we see determines the severity of the patient's hemodynamic compromise. And as well, some important POCUS markers of cardiac tamponade. We talked about right atrial collapse during systole, which is the earliest signs, as well as right ventricular collapse during diastole, and it's almost 100% specificity, as well as a very high sensitivity test of the plethoric non-collapsible IVC. And that's all we have for today.
Hey, thank you, Aggie and Anin, for the presentation. That was a very good overview of tamponade and sort of how we approach it from a from a really basic level, but certainly provides a lot of good information for an undifferentiated patient with various symptoms and various competing comorbidities. Just maybe one brief thing. Go back to the previous slide, the summary slide. I think you mentioned at the very beginning, right atrial collapse being 100% specific. It's actually almost 100% sensitive, not specific. So it's a very sensitive sign, but not a specific sign for tamponade. Okay, so make sure we're aware of that. The way I kind of think about it, the right atrial collapse is more sensitive. Okay, then you go on and maybe try to confirm with the right ventricular collapse, which is specific but not very sensitive. So kind of vice versa there. But certainly, I also agree with you using an IVC. This is one of the few instances where I do think an IVC is quite important to look at, can help rule out tamponade with almost 98% sensitivity, but certainly not specific, as we can probably imagine. I'll open up the questions to the audience. If there are any questions or comments about what was presented today. Maybe I'll ask a question. I guess Aggie, and this is not something we talked about, and definitely not not within the scopes of preliminary POCUS skills. But did you come across anything else on POCUS that can give you, or I guess at least give you an idea that there's tamponade happening?
Yeah, one of the things that came up often would be your mitral valve inflow variability during inspiration and expiration. I believe that's your M mode. And I thought I had a picture of this at the end of the present. Yeah, if you go down 2 slides, another slide. Yeah, so this is your M mode. This is just like a clip of your N mode. I think my image got cut off a little bit, unfortunately. I'm just going to point with some of, if you can see my cursor, here you can see your RV. Right here, and you can see kind of it moving in and out throughout. This is your RV free wall, what I'm pointing at with my cursor. And you can use a mitral valve to ensure you're looking at systole versus diastole. And you can use this versus your pericardium, and you can see that there's a little bit of if you look at the change during inspiration and expiration, I'm not quite sure if it's well labeled here, if I can point out during inspiration and expiration, but I'd say more so around here during inspiration if you have a little bit more variability between the distance here. That's one way you can see if there's assessed for tamponade.
I think I think what you're looking at most, I'm not sure what picture this is, but I think this is M mode over I imagine this is like a subcostal view here, or potentially even personal long. I don't really know, but you're basically, so just to orient the audience, the x-axis is time and the y-axis is basically movement of some kind of structure away or towards the transducer. And so you're seeing basically this RV free wall that's kind of going toward the transducer and then away from the transducer over time. And I think to me, looking at this is more so just another pictorial representation of the RV free wall collapse. Sometimes it might be a little bit tough to look at it in the 2D view and looking at it in real time. But sometimes if you just draw a line and using M mode, and I apologize for describing this to the audience who hasn't done M mode before, you're just giving a better sort of temporal resolution of that free wall collapse. And I think this is what it's demonstrating here. So this is definitely a good way of doing that. I don't know if you guys came up with anything else a bit more advanced hemodynamically to look for tamponade. It's okay if you don't, because this is that's definitely something more advanced. I'll just very quickly mention that you can look at the blood flow that goes through the tricuspid valve or the mitral valve. We call that the transmitral flow, or the tricuspid inflow. And basically, you want to look at the rate of the blood flow that goes in during diastole. And in the setting of tamponade, that rate varies quite a bit. And there are different cutoffs for the variation. But essentially, that's like a sonographic sign of sonographic pulsus paradoxus, essentially. That variation occurs during the respiratory phase. And so you can technically see pulsus paradoxus per se sonographically. But this is with more advanced hemodynamics that I never got into during this block yet. I see Marco has his hand raised.
No, the only question, it's a weird case, right? That's a fairly drastic change in the chest X-ray. Did the CT show any?
They did not. No, they didn't. They didn't do a CT.
Oh, I thought there was a CT on admission.
Oh, sorry. Oh, the CTPE. I don't think there was. I think they said trace pericardial effusion there.
Okay.
The CTPE.
Yeah, and often CT, it's a good screen for pericardial effusion, but in terms of knowing what the actual size is or what it's actually doing, we all know that doesn't really correlate all that well. I mean, with the case, like I just don't know the details of the case, but with the tumor lysis query, did they give lots of fluids at the very beginning?
Yeah, so they ended up giving more fluids, and they kind of questioned whether this is tumor lysis or not. She came in feeling very short of breath. She had an AKI, and they decided to diurese her, but immediately she started having all these electrolyte abnormalities. So they started holding back on her diuresis and then ended up giving her more fluids and, treating her query tumor lysis, and that then resolved. Her chest X-ray then became improved, but she was still a little bit dyspneic. And so that's when they repeated the second chest, well, not the second, but the third chest X-ray. And you see this globular change. But really her shortness of breath, her dyspnea, her orthopnea got kind of better when that chest X-ray was taken. That globular shaped chest X-ray was taken. Her blood pressure, hemodynamics was always rock solid throughout her entire stay. And because she was feeling better, she was walking around, and given her metastatic kind of cancer diagnosis, her family decided to take her home.
Yeah, I think that's quite fair.
I think it would have been a little bit more satisfying if we say, let's optimize the way that she was positioned during her chest X-ray so that we can have a comparable PA chest X-ray to see what is that significant difference in terms of the cardiomegaly. And given the fact that she did have this mildly reduced left ventricular function comparison to just in September when she had that echo, I think she definitely could have had more investigations, but based on family wishes as well as her kind of complex medical comorbidity, that didn't end up happening as per the wish of the family.
And I think it's also given that we're looking at a little bit of decreased LV systolic function also between two echoes we've had previously, it's hard to figure out an optimal volume status for her. So if we were looking at tamponade physiology, we want people to have good preload, give them fluid. But again, if there's decreased LV function, that makes things quite challenging. And also assessing for your effusions, or especially for looking at tamponade physiology, a lot of other underlying risk factors like severe LV dysfunction, which she didn't have, but those things can compromise the severity of tamponade physiology we can see. So I wonder if there's a little bit of, with the fluid, yes or no, which part we were treating versus if we were pushing her more towards heart failure.
I think conceivably with the mixed picture of maybe LV dysfunction, maybe some pericardial effusion, and also the iatrogenic volume administration versus volume removal with diuresis, sort of a mixed picture, and this sort of temporal relationship between over the 3 days. It's a little bit hard to really put our finger on. So this is just an advocacy for our program to say, at the very beginning of this patient's clinical course, maybe a little bit of POCUS might have cleared up the picture a little bit, and we can certainly come back in and have some more serial examinations to help compare. Well, because at this point we're comparing different modalities, and over time, which is a little bit difficult, obviously.
I think it would be difficult to say that this pericardial effusion happened very acutely. I mean, if this is in fact, a approximately 1 centimeter pericardial effusion that's holding approximately 50 to 100 cc's of fluid around her heart, and this all quickly accumulated within 2 days, I think there would be more hemodynamic instability, or at least, maybe she would have been more tachypneic, tachycardic, which that did not happen.
You'd
So I
be
feel-
surprised. You'd be surprised, Aggie. Like it's completely difficult to predict who will get symptomatic or tamponade based on the volume or
Okay.
rate of fluid accumulation. Yeah, it's not predictable at all in my experience. Are there any other questions from the audience or comments? Okay, well, with that then, thank you, Aggie and Anin, for a wonderful presentation and the discussion that came from this. Certainly, if there are any other questions or comments, feel free to contact me. But I guess we'll call it a day there. Thank you, everybody.
Thank you.